Today we will start with other stomach tumors. That is most important one being gastrointestinal stromal tumor. Okay, so the name itself suggests it is related to gastrointestinal system and it is arising from the stroma and it is a tumor. Okay, so where is the most common site? Just like the name suggests, it can arise from the stomach or from the intestine. So first one, most common site being stomach, and then it can arise from small intestine and then colon and then rectum, at last being the esophagus. So from any part of the gastrointestinal tract this tumor can arise. Okay, and it arises most commonly from the gastric pacemaker cells. These are known as interstitial cells of Cahal. Just like heart has pacemaker cells like SA node, stomach also has an pacemaker cell. They are known as interstitial cells of Cahal. If there occurs a tumor from these interstitial cells of Cahal, then that tumor is called as gastrointestinal stromal tumor. Okay, so this expresses a receptor called as tyrosine kinase receptor, which is known as c-KIT. Basically, all these markers will help us to identify or diagnose that this is gastrointestinal stromal tumor. Adukoskara we are just brushing up through this, aita. So if there is a c-KIT marker present or tyrosine kinase receptor will be expressed through GIST, and this c-KIT expresses a marker called as CD117. So while diagnosing, if we are able to detect this CD117, then it is diagnostic of GIST. Other markers, what are the other markers? They can be BCL2, CD34 or PDFR alpha. Okay, that is platelet derived growth factor alpha. Okay, so these are the new markers which are important nowadays, that is DOG1 and protein kinase C theta. These are the new markers detected and these are specific for GIST. So basically these are markers for what? They are marker for GIST. ಈ ಮಾರ್ಕರ್ಸ್ ನಮ್ಮ ಬ್ಲಡ್ಡಲ್ಲಿ ಎಕ್ಸ್ಪ್ರೆಸ್ ಆಗಿದೆ ಅಂದರೆ ಅದು ಜಿಸ್ಟ್ ಅಂತ. ಫಾರ್ ದ್ಯಾಟ್ ರೀಸನ್ ವಿ ನೀಡ್ ಟು ನೋ. ಸೊ ಬೇಸಿಕಲಿ 3 markers we need to know: CD117, DOG1 and protein kinase C. At least these 3 markers we should remember. Okay, so there are 2 types of gastrointestinal stromal tumors, that is spindle cell variety and epithelioid variety. Most common being spindle cell variety is of about 70% and epithelioid variety is about 30%. So okay, till now we have discussed about adenocarcinoma of stomach and now we are discussing about gastrointestinal stromal tumor. So what exactly is the difference between these two? Why is GIST separated from stomach, CA stomach? That is because of this reason. Adenocarcinoma, whatever we were studying, it is a intraluminal growth, meaning if this is a stomach, the growth is occurring within the lumen. Okay, so intraluminal growth. Whereas in case of gastrointestinal stromal tumor, the tumor is growing away like this, outside, that is extramural or extraluminal growth. So what will happen if this is extramural? It will be highly vascular because all the blood vessels like small left gastric artery, gastroduodenal artery, splenic artery, everything will be around the stomach. So all this will be involved and hence this will become a highly vascular tumor. Okay, and bleeding will be the most common presentation here. Along with that, abdominal pain will be sometimes, and patient usually will be symptomatic at advanced stage only. Initially there won't be any symptom, he will be symptomatic at advanced stages. So what are the clinical features of GIST? GIST, most common, just like I said, since it is an extraluminal growth, bleeding will be most common, sometimes abdominal pain will be there, and the most common route of spread is through blood, that is hematogenous. Whenever it is through hematogenous route, the most common site for metastasis will be liver, because whatever the toxic is there in our body, that will be filtered by liver, so tumor cells will also be taken to liver and it will get metastasized there. Okay, it is not associated with lymphatic spread. Whereas CA stomach, we had seen it is spreading to most of the lymph nodes, like axillary lymph node go spread ಆಗುತ್ತೆ, ಇನ್ನು ಸುಪ್ರಾಕ್ಲಾವಿಕ್ಯುಲರ್ ಲಿಂಫ್ ನೋಡ್, ಲೆಫ್ಟ್ ಸೈಡ್ ಸುಪ್ರಾಕ್ಲಾವಿಕ್ಯುಲರ್ ಲಿಂಫ್ ನೋಡ್ಗೂ ಸ್ಪ್ರೆಡ್ ಆಗುತ್ತೆ, ಕೆಳಗಡೆ ರೆಟ್ರೋಪೆರಿಟೋನಿಯಲ್ ಲಿಂಫ್ ನೋಡ್ಸ್ಗೂ ಸ್ಪ್ರೆಡ್ ಆಗುತ್ತೆ. ಸೊ ಮೋಸ್ಟ್ ಕಾಮನ್ಲಿ ಅಡಿನೋಕಾರ್ಸಿನೋಮಾ ಸ್ಪ್ರೆಡಿಂಗ್ ಥ್ರೂ lymphatic route, whereas GIST is not associated with lymphatic spread. Okay, how will we diagnose GIST? We'll diagnose it based on contrast enhanced CT scan, and we are not supposed to do endoscopic biopsy because it is a highly vascular tumor and there is a risk of tumor rupture. So endoscopic biopsy is contraindicated. Okay, now once we have diagnosed GIST, what is the treatment? If it is possible to resect it, then that is called as resectable GIST. If we can cut off the part of the tumor, then it is called as resectable gist. If resection is possible, we'll go for segmental resection or wedge-shaped excision with about leaving 2 centimeters of margin. If it is unresectable, we will have to go for medical management, and there are certain monoclonal antibodies specifically designed for GIST, that is imatinib mesylate, and second line agents being sunitinib, third line agent is regorafenib. Okay, so these are the drugs which we can use for unresectable GIST. So what is the investigation of choice for assessment of response to imatinib? Once we have given imatinib, we should know whether the given drug is working or not. For that assessment, we can use PET scan. Okay, so if there is recurrence of this gastrointestinal stromal tumor, then we can go for PET CT, which is a gold standard in case of recurrent GIST. Okay, so GIST is also a part of a triad called Carney's triad. So GIST alone might not be there. The patient might present with respiratory difficulty, and you can diagnose pulmonary chondroma. Along with that, when you see there is a tumor in the stromal region also, along with that there are some paragangliomas in the adrenal region. So if these three are present in a patient, then that triad is called as Carney's triad. So when you find GIST, you should also look for these two. These might be present synonymously. Okay, so this was about gastrointestinal stromal tumor. So in the tumors of the stomach, we have discussed about classical CA stomach and gastrointestinal stromal tumors. Now coming to certain topics like congenital hypertrophic pyloric stenosis and gastric volvulus. We'll discuss these two. Okay, so just like the name suggests, it is congenital, and pylorus region is stenosed and it is hypertrophic. So just like the name itself suggests, if this is stomach, this is the pylorus region, and here it continues as duodenum. Okay, so pylorus region has certain muscle. If there is hypertrophy of this muscle, circular muscle present in the pylorus, that is called as hypertrophic pylorus. Okay, and because this is hypertrophic, it will lead to obstruction, or the lumen through which the food can pass is reduced or stenosed. Because of this hypertrophy of the pyloric muscle, there is stenosis, and it is from birth. This is known as congenital hypertrophic pyloric stenosis. Now the name has been changed to infantile. ಏನು ಡಿಫ್ರೆನ್ಸ್ ಆಗುತ್ತೆ ವಿತಿನ್ 1 year ಆಫ್ ಏಜ್ ಅಷ್ಟೇ ಇನ್ಫ್ಯಾಂಟ್ಸ್ ಅಂದರೆ. ಸೊ ಇನ್ಫಂಟೈಲ್ ಹೈಪರ್ಟ್ರೋಫಿಕ್ ಪೈಲೋರಿಕ್ ಸ್ಟೀನೋಸಿಸ್ ಅಂತ ಕರೆಕ್ಟ್ ಶುರು ಮಾಡಿದ್ದಾರೆ ಈಗ, ಬಿಕಾಸ್ ಇಟ್ ಈಸ್ ಅಕ್ವೈರ್ಡ್ ಆ್ಯಂಡ್ ನಾಟ್ ಕಂಜನೈಟಲ್. ಕಂಜನೈಟಲ್ ಅಂದರೆ ಫ್ರಮ್ ಇವಾಗ ಮದರ್ಗೆ ಇರುತ್ತೆ ಆಮೇಲೆ ಮಗುಗೆ ಬರುತ್ತೆ, ಈ ಥರದ ಕಂಡೀಷನ್ ಅಲ್ಲ. ಇಟ್ ಈಸ್ ಅನ್ ಅಕ್ವೈರ್ಡ್ ಕಂಡೀಷನ್. ಹೈಪರ್ಟ್ರೋಫಿ ಆಗಿರೋದ್ರಿಂದ ಇಟ್ ಈಸ್ ಅನ್ ಅಕ್ವೈರ್ಡ್ ಕಂಡೀಷನ್. ಹೆನ್ಸ್ ಕಂಜನೈಟಲ್ ಅನ್ನೋ ನೇಮ್ ತೆಗೆದಾಕಿ ದೇ ಆರ್ ಯೂಸಿಂಗ್ ಇನ್ಫಂಟೈಲ್ ಹೈಪರ್ಟ್ರೋಫಿಕ್ ಪೈಲೋರಿಕ್ ಸ್ಟೀನೋಸಿಸ್. ಓಕೆ, just like I said, there is hypertrophy of circular muscle fibers at the pylorus region of stomach. It is an acquired condition, and usually 1 in 3000 or 4000 live births will present with this. Most commonly seen in firstborn males. ಯಾಕೆ ಅಂತೇನಿಲ್ಲ, it is usually just a study conducted, and it is seen most commonly in firstborn males ಅಷ್ಟೇ. And usually the child will be normal at birth, but after 4 or 6 weeks of birth, the child will present with symptoms. So ಏನು ಸಿಂಪ್ಟಮ್ಸ್ ಬರುತ್ತೆ ಚೈಲ್ಡ್ಗೆ? there will be multiple episodes of non-bilious vomiting. Why non-bilious? Because it is in the stomach region. Where does the bile duct open? In the second part of the duodenum. So bile is not yet mixed, hence it is non-bilious vomiting. It can be projectile or non-projectile. Okay na? It depends on ಫೋರ್ಸ್ ಆಫ್ ಕಾಂಟ್ರಾಕ್ಷನ್ ಅಷ್ಟೇ, ಏನೇನಿಲ್ಲ. ಸೊ ನಾನ್ ಬಿಲಿಯಸ್ ವಾಮಿಟಿಂಗ್ ಮಲ್ಟಿಪಲ್ ಎಪಿಸೋಡ್ಸ್ ಇರುತ್ತೆ. ಯಾಕೆ ವಾಮಿಟ್ ಆಗ್ತಾ ಇದೆ? ಬೇಸಿಕಲಿ ದೇರ್ ಇಸ್ ಅಬ್ಸ್ಟ್ರಕ್ಷನ್. ವಾಟ್ ಎವರ್ ದ ಫುಡ್ ಇಸ್ ಕಮಿಂಗ್ ಇನ್ ಟು ದ ಸ್ಟಮಕ್, ಇಟ್ ಈಸ್ ಅನೇಬಲ್ ಟು ಎಂಟರ್ ಇನ್ ಟು ಡುಯೋಡೆನಮ್. ಸೊ ಇಟ್ ಈಸ್ ಗೆಟಿಂಗ್ ರಿಫ್ಲಕ್ಸ್ಡ್ ಆ್ಯಂಡ್ ಇಟ್ ಈಸ್ ಥ್ರೋನ್ ಔಟ್ ಅಷ್ಟೇ. ಬಿಕಾಸ್ ಆಫ್ ದಿಸ್ ದೇರ್ ಈಸ್ ವಾಮಿಟಿಂಗ್, ಆ್ಯಂಡ್ ಇಟ್ ಕ್ಯಾನ್ ಬಿ ಪ್ರೊಜೆಕ್ಟೈಲ್ ಆರ್ ನಾನ್ ಪ್ರೊಜೆಕ್ಟೈಲ್, ಆ್ಯಂಡ್ ಇಟ್ ಈಸ್ ನಾನ್ ಬಿಲಿಯಸ್. ಇಷ್ಟು ಗೊತ್ತಿರಬೇಕು. ಸೊ ಆನ್ ಎಕ್ಸಾಮಿನೇಷನ್ ವಾಟ್ ವಿಲ್ ವಿ ಫೈಂಡ್? ಯೂಶಲಿ there will be a palpable mass in the epigastric region, because this hypertrophy ಏನಿದೆ, this is just like someone going to gym and he has biceps ಅಲ್ವಾ, biceps hypertrophy ಆಗಿ it will be like a mass. So similarly here the circular muscle has undergone hypertrophy and you can feel it like a mass. So that is palpable usually in the region of epigastrium, and then it can be in some patients, it can be seen in right hypochondrium also, but most commonly it is seen in epigastric region. and direction of peristalsis is from left to right only. Direction ಏನು ಚೇಂಜ್ ಆಗಿಲ್ಲ, ಇದು ಹಿಂಗೆ ಇದೆ. ಓಕೆನಾ, ಲೆಫ್ಟ್ ಟು ರೈಟೇ ಇದೆ ಡೈರೆಕ್ಷನ್. ಓಕೆ, ಸೊ ನಾವು ಹೌ ವಿಲ್ ವಿ ಡಯಾಗ್ನೋಸ್ ದಿಸ್? ವಿಲ್ ಗೋ ಫಾರ್ ಅಲ್ಟ್ರಾಸೌಂಡ್, and on ultrasound we'll see the pyloric muscle thickness. If it is hypertrophied, it will be more than 4 millimeters, and the channel length whatever is there, that will be more than 16 mm. Okay na? And transverse diameter of the pyloric muscle will be more than 13 mm. Basically this one is enough to remember. Okay, on ultrasound we'll see pyloric muscle thickness is more than 4 mm, and if suppose we go for abdominal x-ray, then we will be able to see a single bubble appearance, like a one bubble ashte. Okay na? If we do barium meal, we will be able to see string sign. Basically only this, whatever the stenosed region is there, that will be appearing like a string. So it will be appearing like a string. Rest all stomach will be like this. So this is called as string appearance or string sign, or it can be also called as shoulder sign or double track sign. Okay, so basically we need to know 3 different signs on 3 different investigations. USG ಮಾಡಿದ್ರೆ we'll see pyloric muscle thickness. Okay, X-ray ಮಾಡಿದ್ರೆ we'll be able to see single bubble, and on barium meal we'll be able to see string sign. So these are the features which are diagnostic of infantile hypertrophic pyloric stenosis. Also blood work alli we will be able to see dyselectrolytemia. Why does this dyselectrolytemia happen in infantile hypertrophic pyloric stenosis andre? See, it is in stomach. Okay, and there is repeated vomiting. So repeated vomiting andre stomach alli enide HCl ide. Okay, so hydrochloric acid is there. This will also be lost through vomiting. So vomit ಆಯಿತು ಅಂದಾಗ H+ ಕಮ್ಮಿ ಆಯಿತು, Cl- ಕಮ್ಮಿ ಆಯಿತು. Our body, whatever this stomach is there, it has a proton pump which will exchange H+ with K+. Okay, so whenever this H+ is reduced, for compensation K+ will come into the stomach from the blood. Okay, so because of this, what happens? There will be loss of potassium also. So basically all these 3 metabolites will be reduced in case of hypertrophic pyloric stenosis. Hence it is explained here. See, hypokalemia, that is potassium in the blood is reduced because of loss of potassium due to repeated vomiting of mucus. Okay, along with that hypochloremia, that is chloride due to repeated vomiting, and metabolic alkalosis, that is because of loss of H+. If H+ is reduced, blood pH will go up. If pH increases, that is called as alkalosis. Normal pH is to 7.35 to 7.45. Okay, since H+ is lost here, it will be 7.5 or something, and this is called as, and this is because of some metabolic disorder, so it is called as metabolic alkalosis. So what will be the electrolytic feature ಅಂತ ಕೇಳಿದ್ರೆ, metabolic alkalosis along with hypokalemia and hypochloremia and paradoxical aciduria. Okay, only in severe cases you will be able to see paradoxical aciduria, otherwise not. So hence this should be treated as medical emergency, because dyselectrolytemia can lead to arrhythmias and hence death of the patient. So how will we treat this case? This should be treated like an emergency, and we'll go for electrolyte correction first, because that is what will lead to death. So resuscitation by IV fluids and correction of dyselectrolytemia. Fluid of choice is normal saline saku, and treatment okay, this is fluid of choice. This is for emergency management. After this, once we diagnose that all this is happening because of pyloric stenosis, we will have to relieve that stenosis. In order to relieve that stenosis, we will have to cut the muscle which is hypertrophied, and that procedure is called as pyloromyotomy. Pylorus muscle alli ಒಂದು opening create ಮಾಡಿ we are releasing the hypertrophy. Okay, and that was performed by a scientist, and hence the name Ramstead-Fredet pyloromyotomy. Ramstead's pyloromyotomy ಎಂದು ನೆನಪಿಟ್ಕೊಂಡ್ರೆ ಸಾಕು. So this is the definitive treatment of choice for infantile hypertrophic pyloric stenosis. Okay, next coming to a rare condition or a rare thing related to stomach pathology, that is Bezos. So these are nothing but collection of non-digestible materials in the stomach. This can be attributed to psychiatric conditions also, or it can be because of some stomach pathology also. Okay, we'll be studying that. ಓಕೆ, ಸೊ ನಾನ್ ಡೈಜೆಸ್ಟಬಲ್ ಮೆಟೀರಿಯಲ್ಲು ಸ್ಟೊಮಕ್ಕಲ್ಲಿ ಕಲೆಕ್ಟ್ ಆದರೆ ಅದನ್ನು ಬೆಸಾರ್ಸ್ ಅಂತ ಕರೀತಾರೆ. ವಾಟ್ ಆಲ್ ಕ್ಯಾನ್ ಬಿ ದ ನಾನ್ ಡೈಜೆಸ್ಟಬಲ್ ಮೆಟೀರಿಯಲ್ಸ್ ಅಂದರೆ collection of vegetable also, because in humans we have no cellulase enzyme. Cellulase enzyme illದೆ ಇರೋದ್ರಿಂದ cellulose won't get digested and this will get accumulated. Correct? In vegetables there can be this cellulose material. So if this goes on accumulating, there is collection of vegetable and this is most common and that is called as phyto andre plant ಅಥವಾ vegetable ಅಂತ, bezoar andre collection. Okay, so that is phytobezoar. Trichobezoar andre collection of hair. Some children might have an irresistible urge to consume hair, and whatever the hair they consume will go and get collected in the stomach in the form of a ball, and that is called as trichobezoar, most commonly in children. Okay, so that is trichobezoar. Next, pharmacobezoar is collection of drugs. Okay, well, non digestible materials, they won't get digested and they accumulate in the form of like a ball, so this is called as bezoar. Okay, lactobezoar is collection of undigested milk concretions. So this was about bezoars. In that mainly we need to know about trichobezoar. Okay, that is concretion of hair, commonly seen in long haired girls or women, and it is seen in trichophagia, that is habit of eating their own hair. Aita idon psychiatric condition. And there is formation of a hair ball in stomach. So it is a part of a syndrome called Rapunzel syndrome, in which gastric trichobezoar will be there, and this can be so long that it can be extended into duodenum. So stomach will accumulate agadalde, it can take the shape of the duodenum and it can get extended like this. If it is extending like this, it is called as Rapunzel syndrome. Okay, so what will be the clinical features? Obviously there is a non-digestible food like hair, hence the patient will be having abdominal pain, and it can also lead to ulcer, because straight irutte eno ಒಂದು wound ಮಾಡುತ್ತೆ, wound is nothing but ulcer, and there can be obstruction of the gastric outlet. So ಇದಕ್ಕೆ ಮ್ಯಾನೇಜ್ಮೆಂಟ್ ಏನು? ಸಿಂಪಲ್, ಸರ್ಜಿಕಲ್ ರಿಮೂವಲ್ ಆಫ್ ಹೇರ್ ಬಾಲ್ ಆಫ್ಟರ್ ಗ್ಯಾಸ್ಟ್ರೆಕ್ಟಮಿ. ಅಲ್ಸರ್ಗೆ ಏನು ಮಾಡ್ತೀವಿ? ಗ್ಯಾಸ್ಟ್ರೆಕ್ಟಮಿ ಮಾಡ್ತೀವಿ, ಹೇರ್ ಬಾಲ್ನ ರಿಮೂವ್ ಮಾಡ್ತೀವಿ. ಆಫ್ಟರ್ ಸರ್ಜರಿ ವಿ ಶುಡ್ ಪ್ರಿವೆಂಟ್ ಇಟ್ ಅಗೇನ್, ಮತ್ತೆ ರಿಕರ್ ಆಗೋದನ್ನು ತಪ್ಪಿಸ್ಬೇಕು. ಫಾರ್ ದ್ಯಾಟ್ ರೀಸನ್ ವಿಲ್ ರೆಫರ್ ದೆಮ್ ಟು ಸೈಕ್ಯಾಟ್ರಿ. Okay, so this was about bezoars and trichobezoar. And there is one more condition of stomach called as gastric volvulus, which is nothing but circling of stomach one around the other, ಅಥವಾ ಅದಕ್ಕೆ ಅದೇ ತನ್ನಷ್ಟಕ್ಕೆ ತಾನೇ ಸುತ್ಕೊಳ್ಳೋದು ಅಂತ ಹೇಳ್ತೀವಲ್ಲ, that is nothing but volvulus. Okay, so there is a torsion of stomach and it can be of two types. One is organoaxial, other one is mesenteroaxial. ಓಕೆ, ಸೊ ಏನು ಡಿಫ್ರೆನ್ಸ್ ಇದೆ ಎರಡಕ್ಕೂ? ಆರ್ಗ್ಯಾನೋ ಆಕ್ಸಿಯಲ್ ಅಂದರೆ ಏನು? ದಿಸ್ ಇಸ್ ದ ಮೋಸ್ಟ್ ಕಾಮನ್ ಟೈಪ್ ಆ್ಯಂಡ್ ಇಟ್ ಈಸ್ ರೆಸ್ಪಾನ್ಸಿಬಲ್ ಫಾರ್ 2/3 ಅಥವಾ 75% ಕೇಸಸ್ ಅಂತ ಅಂದ್ಕೊಳ್ಳಿ. ಟಾರ್ಷನ್ ಈಸ್ ಅಲಾಂಗ್ ದ ಲಾಂಜಿಟ್ಯೂಡನಲ್ ಆಕ್ಸಿಸ್ ಆಫ್ ದ ಸ್ಟಮಕ್. ಸೊ ದಿಸ್ ಈಸ್ ದ ಲಾಂಜಿಟ್ಯೂಡನಲ್ ಆಕ್ಸಿಸ್ ಆ್ಯಂಡ್ ಸ್ಟಮಕ್ ಈಸ್ ರೊಟೇಟಿಂಗ್ ಲೈಕ್ ದಿಸ್ ಆ್ಯಂಡ್ ದಿಸ್. ಓಕೆ, ಫಾರ್ ದ್ಯಾಟ್ ರೀಸನ್ ಸ್ಟಮಕ್ ಇಲ್ಲಿ ಹೆಂಗಾಗಿದೆ ನೋಡ್ತಿದ್ದೀವಲ್ಲ, ಉಲ್ಟಾ ಲೆಫ್ಟ್ ಟು ರೈಟ್ ಆಗಿಬಿಟ್ಟಿದೆ. ಓಕೆ, ಸೊ ದಿಸ್ ಈಸ್ ಕಾಲ್ಡ್ ಎಸ್ organoaxial volvulus, gastric volvulus. If it is along the vertical line or mesenterical line, this is less common and it is responsible 1/3 cases, and torsion is along the vertical axis of the stomach. ಇವಾಗ ಏನಾಗುತ್ತೆ? This will rotate like this and it will get torsion. Okay, so torsion ಇಂದ ಏನಾಗುತ್ತೆ? volvulus ಇಂದ basically it will hamper the blood supply. Blood supply ಹೋಯ್ತಂದ್ರೆ it can lead to ischemia ಹೋಯ್ತಂದ್ರೆ necrosis. So the person will be losing stomach. It will not be functioning properly also, and it will lead to other complications also. Okay, so this was about organoaxial and mesenteroaxial gastric volvulus. It can also be classified as primary gastric volvulus and secondary gastric volvulus. Primary gastric volvulus andre usually it is associated with congenital asplenia, that is congenital absence of spleen. Okay, and wandering spleen idru agutte. So in primary gastric volvulus, mesenteroaxial volvulus will be seen. Okay, and it is partial or less than 180 degree. Purti vertical axis al rotate agala, ardhambarda rotate agutte, and it is usually recurrent and not associated with any diaphragmatic defect. Primary andre we are unable to find any cause, just associations ಗೊತ್ತು, ಏನಾಗುತ್ತೆ ಆ ಕಂಡೀಷನಲ್ಲಿ ಅಂತ ಗೊತ್ತು. ಓಕೆನಾ? ಸೆಕೆಂಡರಿ ಗ್ಯಾಸ್ಟ್ರಿಕ್ ವಾಲ್ವ್ಯುಲಸ್ ಅಲ್ಲಿ ಇಟ್ ಈಸ್ ಸೆಕೆಂಡರಿ ಟು ಸಮ್ ಅನಾಟಮಿಕಲ್ ಡಿಫೆಕ್ಟ್ ಲೈಕ್ ಡಯಾಫ್ರಾಮೆಟಿಕ್ ಹರ್ನಿಯಾ. ಡಯಾಫ್ರಾಮೆಟಿಕ್ ಹರ್ನಿಯಾ ಅಲ್ಲಾದರೆ ಏನಾಗುತ್ತೆ? ಎಂಟೈರ್ ಸ್ಲೈಡಿಂಗ್ ಹರ್ನಿಯಾ ಇರ್ಬೋದು ಅಥವಾ ರೋಲಿಂಗ್ ಹರ್ನಿಯಾ ಇರ್ಬೋದು. ವಾಟ್ ಟೈಪ್ ಆಫ್ ಹರ್ನಿಯಾ ವಿ ಡೋಂಟ್ ನೋ. So whatever the content is there, that will be pushed up. Okay, so this content will get settled in the diaphragm region. Because of that, there will be volvulus of the stomach, and that is called as organoaxial volvulus. And this is most commonly seen in congenital diaphragmatic hernia, and in case of adults, it is seen in paraesophageal, true paraesophageal hernia. Okay, so basically it is like ಇಲ್ಲಿಂದ ಈಸೋಫೆಗಸ್ ಇದೆ, ಅದರ ಕೆಳಗಡೆ ಬಂದು ಸ್ಟೊಮಕ್ ಫಾರ್ಮೇಷನ್ ಆಗ್ತಿರುತ್ತೆ. So when there is hernia, this is pulled up. Because of this, longitudinal axis ಅಲ್ವಾ, ಸೊ ಸ್ಟೊಮಕ್ ಏನಾಗುತ್ತೆ, ಮೇಲೆ ಹೋಗ್ತಾ ಹೋಗ್ತಾ this will turn this way. So because of that, we can draw stomach ಹಿಂಗಾಗುತ್ತೆ. So this is called as volvulus. So right to left is its stomach, left to right ಆಯಿತು, and that it has rotated, and that is called as organoaxial volvulus. So ಏನಾಗುತ್ತೆ, what will be the clinical feature, how will the patient present to us ಅಂತ ಕೇಳಿದರೆ, patient will be having acute presentation in case of organoaxial. Okay, and it is associated with diaphragmatic defect, that is secondary gastric volvulus, ಅದು ನೋಡಿದ್ವಿ. ಇನ್ mesenteroaxial ಏನಾದರೂ ಇದ್ದರೆ ಅವನಿಗೆ ಪಾರ್ಷಿಯಲ್ ಇರುತ್ತೆ, ರಿಕರೆಂಟ್ ಇರುತ್ತೆ, and it is not associated with any diaphragmatic defect. And there is a classic appearance called as Borchards triad in case of gastric volvulus. ಏನಾಗುತ್ತೆ, obviously when there is rotation of organ on its own, there is ischemia, and because of that there will be epigastric pain abdomen basically, and stomach is usually seen in epigastric region, ಅದಕ್ಕೆ epigastric pain ಬರುತ್ತೆ. Patient will not be able to vomit also, because ಅಲ್ಲಿ ಕ್ಲಿಯರ್ ಪ್ಯಾಸೇಜ್ ಇಲ್ಲ, ಹೆಂಗೆಂಗೋ ಆಗೋಗಿದೆ. ಸ್ಟ್ರೈಟ್ ಪ್ಯಾಸೇಜ್ ಇದ್ದಿದ್ರೆ ಐಸೋಫೆಗಸ್ ಇಂದ ಸ್ಟಮಕ್ಕಿಗೆ he would have vomited, but now it is like stomach is like it is rotated on its own, so patient will not be able to vomit. And similarly we won't be able to insert Ryle's tube also. Ryle's tube insert ಮಾಡೋಕ್ಕೆ ಸ್ಟ್ರೈಟ್ ಇದ್ದಿದ್ರೆ it would have gone till stomach, nasogastric tube, from nose till gastric, that is stomach. But here the pathway is not clear, so we are not able to insert Ryle's tube also. And Ryle's tube, coiling of Ryle's tube is also seen in congenital diaphragmatic hernia, because all the contents are shifted to thorax. Okay, so similar to congenital diaphragmatic hernia, here also we are not able to insert Ryle's tube. So this triad is called as Borchards triad, that is epigastric pain, inability to vomit, and inability to put Ryle's tube. This is called as Borchards triad, and this is seen in case of gastric volvulus. So how will we diagnose this? Basically we will go for barium studies or endoscopy. So treatment ಏನು ಮಾಡ್ತೀವಿ, ಅಕ್ಯೂಟ್ ವಾಲ್ವ್ಯುಲಸ್ ಇದೆ ಅಂತ ಅನ್ಕೋಣ. ಇವಾಗ ಅಕ್ಯೂಟ್ ವಾಲ್ವ್ಯುಲಸ್ ಇದ್ರೆ ಏನು, ಇನ್ನು ಜಸ್ಟ್ ಇವಾಗಿನೋ ಹೆಂಗೆಂಗೋ ಕಾಯಿಲ್ ಆಗಿದೆ, ಸೊ ವಿಲ್ ಹ್ಯಾವ್ ಟು ಅನ್ಕಾಯಿಲ್ ಇಟ್. ಓಕೆ, ಸೊ ಸ್ಟಮಕ್ ಈಸ್ ರೆಡ್ಯೂಸ್ಡ್ ಆ್ಯಂಡ್ ಅನ್ಕಾಯಿಲ್ಡ್ ಆ್ಯಂಡ್ ಫಾಲೋಡ್ ಬೈ ರಿಪೇರ್ ಆಫ್, ಬಿಕಾಸ್ ಅಕ್ಯೂಟ್ ಪ್ರೆಸೆಂಟೇಷನ್ ಎಲ್ಲಿರುತ್ತೆ, ಆರ್ಗ್ಯಾನೋಆಕ್ಸಿಯಲಲ್ಲಿರುತ್ತೆ. ಆರ್ಗ್ಯಾನೋಆಕ್ಸಿಯಲಲ್ಲಿ ಏನು, ವಿಲ್ ಗೋ ಫಾರ್, ಇಟ್ ಈಸ್ ಅಸೋಸಿಯೇಟೆಡ್ ವಿತ್ ಡಯಾಫ್ರಾಮೆಟಿಕ್ ಡಿಫೆಕ್ಟ್, so we'll go for repair of diaphragmatic defect. So acute andre it is organoaxial with congenital diaphragmatic hernia or any defect irutte. So we'll hengengo coil agiro stomach na we'll uncoil it, and then we'll go for closure of this defect. In case of spontaneous andre it is usually mesenteroaxial, and in that case we'll go for detorsion and followed by fixation of stomach, that is ಗ್ಯಾಸ್ಟ್ರೋಪೆಕ್ಸಿ. ಏನು ಮಾಡ್ತಾರೆ, ಇದರಲ್ಲಿ ಯಾವ್ದಾದ್ರು ಒಂದು ಬೋನಿ ಸ್ಟ್ರಕ್ಚರ್ ಹುಡುಕ್ಬಿಟ್ಟು ಅದಕ್ಕೆ ಸ್ಟೊಮಕ್ನ ಸೂಚರ್ ಮಾಡ್ತಾರೆ. ಓಕೆ, ಲೈಕ್ ದಿಸ್, ಹಿಂದ್ಗಡೆಯಿಂದ ಹಿಂಗೆ ಸೂಚರ್ ಮಾಡ್ಬಿಡೋದು. ಸೊ ಇವಾಗ ಏನಾಗುತ್ತೆ, ಇಟ್ ಕಾಂಟ್ ರೊಟೇಟ್ ಆನ್ ಇಟ್ಸ್ ಓನ್, ಬಿಕಾಸ್ ಆಫ್ ದ್ಯಾಟ್ ರೀಸನ್ ಇಟ್ ವಿಲ್ ಸ್ಟೇ ವೇರ್ ಇಟ್ ಈಸ್. ಸೊ ಗ್ಯಾಸ್ಟ್ರೋಪೆಕ್ಸಿ ಈಸ್ ಡನ್ ಇನ್ ಕೇಸ್ ಆಫ್ ಸ್ಪಾಂಟೇನಿಯಸ್ ವಾಲ್ವ್ಯುಲಸ್, ವೆರಸ್ uncoiling of the stomach and repair of the diaphragmatic defect is done in case of acute volvulus. Okay, so these are the appearances, how it will appear in case of endoscopy and investigations, other investigations like ಹೇಳಿದ್ನಲ್ಲ ಇಲ್ಲಿ ಬೇರಿಯಮ್ ಸ್ಟಡೀಸ್ ಮಾಡ್ತೀವಿ ಅಂತ. ಬೇರಿಯಮ್ ಸ್ಟಡೀಸ್ ಮತ್ತು ಎಂಡೋಸ್ಕೋಪಿ. ಬೇರಿಯಮ್ ಸ್ಟಡಿ ಮಾಡಿದಾಗ ಹೆಂಗೆ ಕಾಣುತ್ತೆ ಅಂದರೆ ಇಟ್ ವಿಲ್ ಅಪಿಯರ್ ಲೈಕ್ ದಿಸ್ ಟೀ ಪಾಟ್ ಸ್ಟಮಕ್. ಸೊ ಟೀ ಪಾಟ್ ಹಿಂಗೆ ಕಾಣಿಸ್ತಿದೆಯಲ್ಲ ಆ ಥರ ಕಾಣಿಸುತ್ತೆ ವೈಲ್ ಡೂಯಿಂಗ್ ಬೇರಿಯಮ್ ಸ್ಟಡಿ. ಫಾರ್ ದ್ಯಾಟ್ ರೀಸನ್ if we do barium study and if we are able to detect it as teapot stomach, then diagnosis is gastric volvulus. Okay, otherwise on you can say hourglass stomach also, like this. So half of the stomach is here, half of the stomach is here, because it has twisted on this point. Okay, so that hourglass stomach and teapot stomach are the classical appearances which we will be seeing on investigations in case of gastric volvulus. So this brings us to the end of stomach. So we have discussed gastrointestinal stromal tumor today. After that, infantile hypertrophic pyloric stenosis, then Bizarre's. After that, we discussed about gastric volvulus. Okay, ಏನಾದ್ರು ಡೌಟ್ಸ್ ಇದೆಯಾ ಇದರಲ್ಲಿ?